All right, hello everyone. My name is Brett Fromer. I'm president of ATSU Missouri Students for National Health Program. And today we have Dr. Ed Weisbart, came from Columbia, Missouri, to come and speak about current issues in the American healthcare system and single payer as a proposed solution to many of those issues. So please give Dr. Weisbart a warm welcome and take it away.
Thanks. Can you hear me? Oh, good. Okay. This is really a cool AV system. I can't hear any echo of it, so excellent. This is, I think, my third time here, yeah? Something like that. Raise your hand if you've been here before when I've been speaking. Good, so a lot of fresh people. So I'm actually from St. Louis, not from Columbia. So I'm Ed Weisbart. I'm a family physician. We're going to be talking about healthcare. We're going to be talking about how healthcare performs today in the country, some of which you know, some of which you may not know. We'll be talking about what to change under it, and as you heard from Brett, my proposal to you that the evidence is pretty strong in favor of improving Medicare and giving that to everybody, but I'll present information around it, and you make your own decision. And the last section of this will perhaps be the most important to you, because we'll talk a bit about how that will affect physicians. It's pretty obvious how that would affect patients in many ways, but the physician piece doesn't get a whole lot of attention, and we'll talk a bit about that at the end, salaries and things. Lastly, just to say that part of the reason that I'm here is because of that guy, Dr. James Adams, who just snuck in, a radiologist who's been incredibly helpful and interested and engaging and supportive on all these and many other interesting things. So anyway, thanks. Thanks, and I'm glad you made it, snuck it in. So my background is I'm a family physician. I practiced for 20 years in Chicago, delivering babies and taking care of old folks and everything in between and doing stuff like that. And I still moved to St. Louis in 2003, and I don't have a full practice like that anymore, but I volunteer at a safety net clinic, or several actually, at least once a week, just even a few days ago. So I'm still seeing patients on a regular basis. And I moved to St. Louis in 2003 to become chief medical officer at Express Scripts, which is a large, Fortune 100, I think Fortune 50 company now. And it taught me a lot about the business world of healthcare, and I think you'll see it informed a lot of how I speak to the issues, because the business side of it actually is pretty compelling to me, and I think it has to be, or this would be a crazy strategy. And then when I retired from that, I got coerced into putting together what was originally the St. Louis and now the Missouri-wide chapter of an organization called Physicians for a National Health Program. And we have an incredibly active student chapter, student chapters all over the country, and I believe the one here is terrific. So we basically are a single issue advocacy group. We do research and education around Medicare for all. That's the core issue. In Missouri, we also focus on trying to advocate for expanding Medicaid, because our group believes that's an important strategy for our state as well. So that's me in a nutshell. Here's sort of the problem, our life expectancy. These countries all live longer than we do. Here's us, and my charts will always be the different colored country. Some of them will have so many countries along the bottom that you won't be able to actually read them very well, but will be the different colors. Some will have a lot less countries, and that's not because I'm cherry picking what to show you, it's because they come from different sources. They'll all have data on them, they'll all have a footnote on the bottom, so if you need me to tell you exactly where my data source is, I can do that. Some of them you'll be familiar with, like you're familiar with this. I'm showing you this for a reason, which will become apparent a little later on. Some you probably will not have seen. This again is one that you're familiar with. We're spending double what any other country is spending on average, so we knew that. You probably didn't know this, that more than half, roughly 2/3 of what we spend on healthcare today is already coming out of our tax dollars, and that's important when you hear people say, well, we can't afford this on taxes. Well, our taxes are already paying for the majority of healthcare in the country. You don't see that number very often. You just see this, and then you might see some things like this. But you have to consider tax subsidies. You have to, for employment, when your employer gets a tax break for having given you healthcare, that's basically out of taxes. Government worker benefits, the Department of Defense, the VA. You usually only see these last two. You usually only see these two, Medicare and Medicaid, as government-funded healthcare. But in reality, if you think about it, It's the majority of what we spend on healthcare comes from our tax dollars. Why do we spend so much? Is it because we're running to the doctor? You know, we're all saying how much patients go to the doctor way too much. You know, people say that. Here we are. Patients actually, in the United States, actually see the physician less often than they do in most other countries. We actually have less physicians than many other countries. But we lead the world at this. Lead the world at this. And it turns out if you do the arithmetic and add up how many people are working in billing and accounts receivable for hospitals, how many people are there? There's labor statistics. You can do this. Add up how many people are working in total in billings and accounts receivables just for hospitals and divide that by the beds in the hospitals. We actually have more people in billings than we do in, so every hospital in the country on average could put somebody full-time from the billing department at the foot of every bed and have an entire department left over. No other country does that. And I bring it up because we can't do that with nurses. You know, we don't have that kind of nursing resource. And this is an incredibly expensive diversion of funds that could be being spent on nursing staff or on physician staff or what have you. Instead, it's these wonderful people in the billings department, but they're, you know, what are they adding? Are they adding what we really want? At the end of the day, healthcare administration accounts for almost a third of what we spend on healthcare. And in other countries, it's more like 7 to 10% or so. So, why do we spend so much on healthcare? We spend it a lot because of the complexity of how we've organized it, and I've touched on that a little bit. We'll come back to it more, and on prices. I'm not going to dwell too much on the pricing piece because tonight we actually have a great opportunity for you to see this movie, Big Pharma Market Failure. It's at the Downtown Cinema 8 at 6:45 tonight, free, so come on and bring your family and friends. And this goes into quite a bit more about prices, specifically about pharmaceuticals, but it's a generalizable lesson. So come tonight, and we'll tell you more about that again in a little bit. So how is healthcare organized elsewhere in the world? Can we look around the world and see how healthcare is organized? And it turns out you could do a perhaps inappropriately high-level summary and say that there's 3 ways. There's obviously a lot more granularity we could do to this, but for today we'll just say that there's 3 ways. One is this, which is not what we're talking about. This is a national health service. This is where the government actually owns the hospitals. They actually directly employ the physicians. So that's the definition of socialism, right? Socialism is government owning the means of production, as you recall. That's socialism. So this is socialized medicine and is not what we're here to talk about. This is how healthcare is organized in the United Kingdom. This is what we do in the Veterans Administration. And I could make the argument that this actually works really well. It's certainly the least expensive model. I could show you data, but it is, you know, but that's not what we're talking about. I don't think that's terribly consistent with anything that would gain residence in the United States. And I personally, just speaking for myself, would not actually prefer to work as an employed member of, that's not what I want to do. So that's actually not what we're here to talk about. You could almost call it an extreme model. That's with the government really taking over healthcare, not what we're talking about. There's another extreme model way over here on the far right side of your screen, which is what I would call wild, wild west health insurance. And this is how we have it today. I'm not going to belabor this, but this is a very complicated, highly fragmented system with gaps that people constantly fall into. I could call our system here extreme by the definition of we're the only country in the modern world that does this. And so that, you know, good or bad, that's extreme. The reason I'm framing it like this is because there's what I consider to be a very conservative model in the middle, which is only talk about the insurance. And really that's what we're doing today. We're just talking about health insurance. So it's just the insurance side. So it's making the insurance publicly funded, sort of having the government almost serve as an escrow account for the insurance model, having the insurance be publicly funded. But although there's many things on the delivery side we probably should also be talking about, this model doesn't necessarily talk about that at all. So we could maintain private delivery, and a little bit later I'll be explaining to you how I think this actually greatly strengthens our ability to do privately delivered healthcare. This is how healthcare is organized in Canada, and it's certainly how Medicare is organized. And you may or may not realize it, but the word Medicare was invented as a word by the Canadians. And Lyndon Johnson heard that word and said, hey, I like that. And so in '65, when he passed the bill that created Medicare and Medicaid, he took the Canadian term for it. And so anyway, Medicare, that's how this is set up. And that's what we're here actually to talk about, primarily is that model. And There turns out that there's a bill in Congress called H.R. 676. So everybody repeat that with me, H.R. 676. That's the only reason I come here. I just love to hear a group say that anyway. So H.R. 676, and we're going to walk through that a little bit. There's about to be a tandem bill in the Senate. We're not sure of the details of that, but at the moment there's this bill. And it says just two things, really. It says improve Medicare and expand it. Improve Medicare. Everybody who's familiar with Medicare would quickly say that there's a number of flaws with Medicare. It was set up in 1965. It's had a few revisions, but there's problems with it. It's far from perfect. So these are the things that have to be changed. There's gaps in Medicare's benefit design. If you're diabetic and I want to send you to see a cardiologist, I can do that. I want to send you to get bypass surgery, I can do that. I want you to get your cataract fixed, I can do that. But if I want you to spend an hour with a nutritionist, Medicare doesn't cover that. So there are gaps, important gaps in the benefit design. There are also significant financial barriers to care in Medicare. So I don't know if you're familiar with it enough yet, but there are significant copays and deductibles and such. And so as a consequence of that, people who just have traditional Medicare sometimes still can't afford to get things that they want. And so if they can afford to, most seniors with Medicare, if they can afford to, will purchase a supplement or a wrap to fix those gaps. Or they might opt for the privatized version, Medicare Part C, Medicare Advantage, which is an entirely different choice. We could talk about that in some detail. Medicare Part C, in case you haven't realized it, Medicare Advantage is actually managed care. It is an HMO. If you go to Medicare Part C, the Advantage Medicare, you have a directory of which physicians you can go to and which ones you can't. And we could have a whole discussion of that. But my point being that Medicare has limitations today. People are buying supplements and wraps and making other choices to complete Medicare. We know what those problems are. Embed those fixes into the improved aspect of Medicare. When we say improved Medicare for all, that's what we're talking about, is getting the benefit design fixed and eliminating these significant financial barriers. So embed that into Medicare, give that to everybody. And that's what we're talking about. Giving it to everybody means everybody. It means give it to the president, give it to the mayor, give it to the dean, give it to you, give it to me, give it to your nephews, give it to teachers, give it to everybody. And that's important because if everybody is in the same program, that's the only way you can actually get the bureaucratic efficiencies that we're going to be talking about in a moment. That's also the only way to really protect the program, because as you've seen all the time in the news the last few years particularly, it's really fun for politicians to go and try to attack this program or try to, in Missouri, we just saw MoRx getting eliminated. We've seen all of these important healthcare programs getting whittled away because, well, nobody cares about that group. Well, I'm not going to have an abortion, so I don't care about that. Well, I don't care about this piece of it, so that's not important to me. When we're fragmented, we don't have the ability to fight together and preserve it. If we were all in the same program, it would be very difficult for Congress to really damage the program because they'd be doing it to their own family and friends too. So two reasons why it's really important to have everybody in the same program. And if you did that, then you wouldn't have to have these crazy fights we have like we do about Medicaid and such. You wouldn't have to have those because everybody would have insurance. So what are we talking about? I'm using the phrase Medicare for all. You've heard other phrases. You've heard national health insurance. You've heard the words single payer, right? Can somebody explain to me the difference amongst those things? Yeah, you can't because it's almost no difference. It emphasizes different aspects of the same thing. So let's talk about what this actually means. Here's Americans, right? Here's all of us. Here's the stuff we want, doctors, hospitals, prescription drugs, all that kind of thing. And in between us is all the money, right? Of course, there's a money flow from there to here. And then the money today is managed by all kinds of groups. There's the United States government paying for the military and the post office and Medicare and Medicaid and such. There's the states, there's labor, there's schools, there's businesses, there's all these insurance companies. These are all considered payers of insurance, right? So we have what's called, uniquely in the world, a multi-payer model, right? That's why we call it a multi-payer model. Instead of that, get rid of all that and just have a single payer model, hence the phrase single payer, where taxes, escrow basically, and then distributed through this process. Of course, I'm simplifying it, but that's what the phrase single payer means. One payer instead of hundreds and thousands. I don't know how many there are. I ran out of fingers when I tried to count. So that's also national health insurance. That's a synonym, right? Because it's insurance, health, for the nation, national health insurance. It's also almost synonymously Medicare for all, because as I'll try to argue towards you, working through the Medicare model would be the easiest, simplest, most efficient, and smartest way to go about doing this. So those are basically synonyms. Now you know. Okay, so most important, I told you my background in business, most important, largely important to me is that it has to make economic sense. And I'm here to tell you that there's 25 studies, maybe more, that have looked at this and have said that yes, Medicare for all makes economic sense for the country. Goes back decades. There's tons of new and historic data about this. And there's one or two that show a somewhat different conclusion, and I'll explain that to you in a moment. But there's dozens, literally, that show this. Let me walk you through one that's sort of a good high-level summary. This was developed by Professor Jerry Friedman, who was the head of the Department of Economics at the University of Massachusetts in Amherst when he produced this. And he said, of course there would be new costs, but there would be new savings. So are you convinced the green box is big? And so there's actually numbers in each of these. So the new costs. What are the new costs? Well, first, you'd have to pay more for Medicaid patients. I don't know if you've seen very many Medicaid patients today, but if you have Medicaid today in Missouri, I'll get $30 for an office visit for a 99213. If you have Medicare, I'll get about $100 for the same 99213. And if you have Blue Cross and Blue Shield, I'll get about $130. Just ballpark crude numbers. About $130 for the same office visit, the same CPT code, the same ICD-9 codes, the same everything. But I'm going to get paid 30 from you, 100 for you, and 130 for you, which means I want to see you all the time. And you know, your blood pressure, it's not so bad. You know, so I have to do an assessment of your economic value to me before I let you in my office. And I don't want to have to do that. That's not why I went to medical school. I don't want to do that. That just doesn't feel right. So part of the way to have us not have to do that is you have to pay more for Medicaid patients, because I can't keep my doors open. I don't know how people do that. If I see very many, you can't make up a negative margin on volume. So it would cost something. That's how much, according to Professor Friedman. There would also be a cost for providing care to the uninsured, of course, and people would all start doing stuff. You know, it's the moral hazard. Maybe it's not really a hazard, but people would start doing stuff. They'd go to the dentist, because our proposal includes dentistry. They'd get more home health care, because again, the proposal includes that. So they're getting all kinds of stuff that would cost more. I argue that that's not necessarily a bad thing. Okay, so there would be new costs. Now, the studies that disagree with the conclusion stop at this point, or maybe they have a little bit of this stuff that I'll show you in a moment, but they typically stop at this point and say, well, gee, Mr. Touchy-Feely, I like that too. I'd like to cover the world with health care, but have you seen the national debt? You know, we can't afford to do that. These are new costs. We can't take on the new costs. I would say if you're stopping at half of the balance sheet, you're either really uninformed, which I don't think is the case, or you're intentionally misleading people. And the two studies that came to this conclusion and didn't include all, or certainly most, of these parts were in the USA Today and the Wall Street Journal and all that stuff right around the general election a few months ago. So what's on this side that you have to consider? Tell me if you think these things don't need to be considered, but I think they have to at least be considered. One is, of course, you're asking the government to administer one program instead of the couple of dozen programs, and there's going to be some greater efficiency from one program than dozens of programs. Turns out that's not a very big savings, and I'll show you why. Turns out that the government's actually, for better or worse, pretty efficient at doing this, and I'll show you some more data about that. Secondly, health insurance administration, right? We would not need as many people working on administering health insurance, since it would be far simpler. Administrative costs to hospitals and doctors. The average physician, last time I saw, was spending roughly $85,000 a year on office staff. The average physician was spending roughly $85,000 a year on office staff who do nothing but manage the health insurance industry for them. They help their patients find the right CAT scanner or what have you. That's crazy. So how would you save that money? What does that mean? We just suddenly get a windfall? We don't have to pay $85,000 a year? No. That would mean that you could actually set up the identical fee schedule that we have today for physicians and reduce it by that much, and we would stay whole. So there's that. And then lastly, of course, you have to allow the government to negotiate the prices of drugs and devices. And that's the topic of tonight's movie. If you come to the movie tonight, you'll hear more about that. So this is the easiest one to find absent from these studies. So when you look at the two studies that suggest that we can't afford to do it, look and see how much savings they have from letting the government negotiate the prices of drugs. And you'll find zero. Zero. So that's really easy to find. We can argue about the numbers, and indeed there are other economic analyses that come to different buckets and different models and different assumptions and have different, but they all show break even or better for doing this. But if you look at the ones that don't show break even, they don't have things like this. Now maybe 178 billion isn't the right number. Maybe it's a different number, but I promise you it's not zero. So there's that. So why are we talking about Medicare? Why build it on Medicare? What's so great about Medicare? It means not wasting money. I hate wasting money. So here's the overhead of the large insurance companies in the country for the first quarter. And this actually is their, if you're wonky, this is 100% minus their medical loss ratio. That's how I just call that overhead, so I don't have to discuss what medical loss ratio is. So their overhead is around 15 to 20%, which is what's mandated under the ACA. It hasn't really changed very much, actually. There's their overhead as reported to the SEC. And then here's the overhead for traditional Medicare, according to the Medicare Trust Fund report, 1.4%. And that's all in. That's including FBI agents. That's including IRS staff. That's including the brick and mortar for their buildings. That's including what it costs to collect your taxes to do this. All the overhead, that's including everything, 1.4%. Now, many would say that this number should be higher, or more like around 2%, because there are things Medicare should be doing that it's not funded to do, like more fraud and abuse work. Probably should have more resources for that. So anyway, it's a pretty low number. If you add in the privatized versions of Medicare, which we were starting to allude to about Medicare Advantage, Medicare Part C, it goes up to 6%. Still, even with that, astronomically better, which means that all of this, we're wasting. We're spending that money and not getting anything really out of it. So you've seen these ads, right? Here's an ad for United. Here's an ad for Anthem. So why do they play ads like, what's the imagery here? The imagery is that they're going to get healthier? No, the imagery is that these insurance companies are doing their outreach to find the healthiest people. If you can relate to her, or if you can relate to this, you're the kind of person that they want to advertise to. And if you're confused by it, there's actually a whole industry of people who are advertising about how to help you buy it. None of this is needed. All of this is expensive, and all of this is a consequence of how complicated our system is, and we pay for that in our premiums. And that's crazy. So not wasting money means you don't spend money on marketing, and then we won't walk through all of these, but there's all of these other buckets of money that private insurance pays for that Medicare doesn't pay for, that accounts for why they have 1.4% overhead versus the 18 to 20% overhead. So Medicare also means freedom of choice. Really important to me. So meet my mother-in-law. There she is. It kind of freaks me out when I see her up there. Hi, Ma. I'll behave. I don't know why I put this in. It kills. Anyway, there's my mother-in-law. So she lives in Ormond Beach, near Daytona, Florida. And she's in her 80s, and she has a pretty, I don't think you can call it rare. She has HOCM, hypertrophic obstructive cardiomyopathy. She has HOCM. And it's genetic. So thanks, Ma. Turns out my wife may have it. I don't know yet. Her version of it tends to show up in your later years. So she has this. Turns out that there's only 3 centers in the country that are actually pretty expert at treating this. None of them are in Florida. One of them is in St. Louis, actually. The St. Louis Center has treated, I think, 90 patients for it. So it's not, this isn't and that's one of the 3 best in the country. So we decided that the best place for her to get her cardiac ablation, which is what she needed, was to come to St. Louis. So we did. Medicare wouldn't buy her a plane ticket, better than them. So we brought her to St. Louis. Yes, I flew my mother-in-law to St. Louis to give her a heart attack. We flew her to St. Louis, and it was completely covered. She has a supplement, and it was completely covered. She didn't pay anything for this. So I can't do that, right? I have Cigna. I buy it through the marketplace. I pay, I think, $1,500 a month. It's probably going to go up to over $2,000 next year. But they tell me what doctors I can't go to, and they tell me a lot of doctors I can't go to. And so if I had this condition, my wife may well have this condition, and we live in St. Louis, but what if there wasn't a center in St. Louis? What if the center was in Philadelphia? That wouldn't be in our network. I wouldn't be able to take my wife to the best place in the country for this condition. I'm paying for them to tell me that I can't use where I think she should go. My mother-in-law has Medicare. She can go anywhere that she wants. And she doesn't want you to mess with them. That one really freaks me out. So some data around that. There's roughly 685,000 practicing physicians in the country. Almost 10,000, not quite 10,000, have said that they don't take Medicare. Thank you very much. That means that more than 98% of physicians in the United States accept Medicare. If you have Medicare, you can go to any doctor in the hospital in the country pretty much. It means you're back in control of your health care, and that's how it should be. So Medicare also means that we get healthier. So you know this part of things a little bit. So here's my wonkiest chart, and I apologize, but y'all can handle this. So here's our life expectancy by age. So ranked against 17 other peer nations: Switzerland, Canada, Denmark, Finland, France, Germany, many others. Life expectancy by age ranked against other countries. So you know as you get older, your projected life expectancy goes up, right? Because when you're 75, you're not going to die when you're 20. When you're 20, you might die when you're 40. So, as you get through those years, your life expectancy is longer, right? Your projected life expectancy becomes longer. That's not what we're talking about. This is 7-year-old Americans compared to 7-year-old Italians, compared to 7-year-old Greeks, compared to 7-year-olds all over the world. Here's 35 to 39-year-old Americans, future life expectancy ranked against 35 to 39-year-olds around the world, and so on. Okay, so you know that we lose on this. I showed you that was my first slide, I think. We lose on this. There we are at the bottom of the list, right? You knew that. Here's the part you didn't know. Something happens when you turn 65. Did you know this? Did you know this? This is from the Institute of Medicine, so I'm not making, unlike my other slides, I'm not making this one up. No, this is from the Institute of Medicine. And so I would say that this tells you that we have actually the best healthcare in the world. I would argue that this tells you that America has the best healthcare in the world. We have the best doctors and the best hospitals, because how in the world could this have happened were it not for how great our medical system is? The problem is that you can't use it. The problem is it's priced so high that people can't get into it. And my argument is that we don't have to price it like that. We can fix that. So that's my point. And here's some data, more data about that. United States versus Canada, right? We actually have a non-blinded but a prospective controlled study of this strategy. So in 1971, it turns out that healthcare outcomes in the United States and Canada were really similar. Really similar. Our healthcare cost as a percentage of GDP, which I'll show you, were almost the same, and we're following the same cost trends. And our life expectancies were within a few months of each other. Okay, then 1973, President Richard Nixon signed into law the HMO Act, ostensibly to reduce the cost of healthcare in the country. So we started the managed care experiment. And around 1971, actually, the last province came on board in Canada, and Canada fully implemented, essentially, their national health insurance program. So we were the same, and then we had a fork in the road: managed care, national health insurance. Well, what happened? We have data. I love data. We have data. Here's our healthcare cost as a percentage of GDP. The relentless climb up. We're now somewhere around 18%. And then here's the HMO Act being passed. Hard to see any impact on the cost trends. So there's that. And then here's Canada's. We were the same. And then the slope of the curves, not just a drop in the y-axis from price negotiations, a change in the slope of the curves happened, so that now they're spending roughly half. We also have another important difference in outcomes. 14% of Americans now say they have an unmet healthcare need, and the same survey says that 11% of Canadians would say that they have an unmet healthcare need, so a lot fewer Canadians. In America, 1% of us say we have an unmet need because of a waiting list or a service that's unavailable, which is different than when they can't afford it. There's you can't afford it, cost. And then lastly, a smattering of other reasons. In Canada, they say they have a waiting list that's causing most of the unmet healthcare needs. So remember, I just showed you life expectancy. These unmet healthcare needs are not for lymphoma or leukemia, for heart attack, for strokes, for life-threatening thing, for pneumonia. It's not for that. It's for a hip that hurts, and that can be horrible. And somebody just told me a story about their family who believed that their that their great uncle in Canada died from having to wait for his hip surgery. He had a heart attack, 18 months waiting for his hip surgery. I would submit that if the pain from the hip, waiting for your hip, was going to kill you, I would be worried that the surgery might be risky too. I don't know, but there are waiting lists in Canada. I'm not going to argue that point. There are waiting lists in Canada. I submit that they're generally not for the life-threatening important things. They're for the important but not life-threatening things. The reason they have this is because they spend half of what we spend, right? They made a decision that they want to spend half of what we spend. Nobody's talking about our spending half of what we spend. The other thing is that they measure this. You can go online and find this data. We don't have that at all. Then they have costs. It's not perfect. And then other reasons. So at the end of the day, here's life expectancy. There's Canada versus United States from 1979, as far back as the data goes on this. And now they live 2.5 years longer than we do. So they spend less and we live longer. Before we go on, we got a few more minutes to talk about the impact on physicians. But if you found this discussion interesting so far, and just say yes. If you didn't, you just don't tell me. No. If you found this interesting, Brett and his friends are going to pass around this and give us your email information particularly, and I would love to let you know when we're doing future things in the community or occasional. I'm the one who writes most of the emails, and so it's like 1 or 2 a month. It's not a lot. So fill this out, and then you'll see this box, need a P&HP speaker. If you check that box, I'll reach out to you and we'll figure out what group it is you're talking about. Think outside the box. Think about not just sort of like friendly, liberal groups. Think about all the groups that you're also involved with who don't have this bias. Think about, a Rotary Club or a conservative group that you're a part of. I'd love to go and talk with them. Anyway, check the box and we can talk. I'll reach out to you. So what does this mean for physicians? First, in case you haven't noticed, we're not very happy here in the United States of America. Physicians in the USA are the second least happy physicians in the world. German physicians are actually less happy, less satisfied. I won't comment. I don't know why, but there's that. And part of it is this. Here's what it's like to practice family medicine in Canada. A lot of numbers here. The one I want to call your attention to is non-clinical administration. Canadian family physicians, and you could probably find similar data for other specialties as well, but it's hard to show everything. Canadian family physicians spend 2.4 hours a week on non-clinical administration. Compare that to what it's like here, right? A lot of doctors here are spending 10, 12, 20 hours a week. Some spend more time on non-clinical administration than they do on patient care. And it turns out that we become increasingly dissatisfied with our practice as our time on non-clinical administration goes up. So this is an important deal. And remember, in Canada, they're way down there. So that's one reason we're unhappy, is because we're asked to do so much stuff that you're not being taught. It's stuff you don't want. And here's incomes, all right? There's Canadian incomes. I'll just let you look at those numbers for a moment. Not a terrible set of numbers. And then here's another piece of this, which is practice overhead, right? That $84,000 worth of staff that you don't have to spend, and malpractice. The most common reason to sue in the United States is because somebody had a bad outcome, whether it was or wasn't our fault. They sue for a bad outcome in large part because they're terrified about who's going to pay for the future cost of their medical care. Well, in Canada, the future cost of their medical care is in the water. They have that as a benefit whether they're working or not. The future cost of their medical care is unchanged. The access to the future medical care is unchanged, whether they're able or disabled or working or what have you. So they don't have as much of a reason to sue. And when they do sue here, the biggest chunk of the judgment against us is actually for the future cost of medical care. So at the end of the day, malpractice in Canada is a fraction of what it is here. Medicine's really tough. The average American physician has, in Missouri, I don't have data for the country, but the average single practice physician in Missouri has over $200,000 of accounts receivable. You know what accounts receivable is? That's not charity work that you've written off. That's work that you've done for which you expected to be paid, that you've submitted a bill for, and that nobody's paid you. And that's typically the insurance industry. The average physician in Missouri, according to the Missouri State Medical Association, has over $200,000 of bad debt. And most of that is more than a year old. And that doesn't happen in Canada. Here's a family physician from Michigan who moved across the border to Canada And he says that, that doesn't happen. It doesn't happen. Everybody's got the same insurance. I plug it into the electronic system, and within 2 weeks, the money appears in my checking account. So at the end of the day, American physicians are actually moving to Canada. We all know, well, this actually started a few years ago, 10, 12 years ago, where American physicians began migrating to Canada, and Canadian physicians began returning to Canada. So we all know a Canadian physician practicing in the United States. They typically look like me or older, and they're increasingly in the minority, because it turns out that Canadian physicians who often came here have decided sometime around the early 2000s that they wanted to repatriate. So it's not that bad. Nearly half of US physicians, the most recent survey I've seen, said that they want national health insurance, and it varies by specialty. So some specialties more than others. I'll let you look at that and figure out what you think the patterns are. I have some thoughts, but at any rate. So how would this impact physicians? First, it would decrease our administrative costs. Secondly, it would increase our satisfaction. And thirdly, it would preserve our earning potential. So this bill, Medicare for All, HR 676, remember?
HR 676.
Yes, thank you. So it was introduced by John Conyers of Michigan in 2003, and it had 38 co-sponsors when he admitted it, or submitted it, and it's been in Congress every session with the same bill number, and it grew from that to this right before the ACA was passed. Before the ACA, it was actually the most popular piece of healthcare legislation in the country. And then when the ACA came in, people were getting a little more cautious about doing anything. People who supported this wanted to not disrupt the ACA, so it became more ambiguous. But we had a change in our government not too long ago, you may have noticed, and now this bill has 117. It has more than half of the Democratic representatives in the US legislature. More than half. We've never done that, ever done that before. And there's interest and discussion on the other side of the House, although there has yet to be the first, it's yet to become bipartisan. But the issues I raised to you are nonpartisan. They're business, basically. So I'm pretty excited by that. Last thing, if you haven't filled out this sheet, please find it. And there's 4 of them floating around someplace. Stay in touch with us. And there's that. And then come tonight. And I think we have 10 minutes or so for talking. Yes?
We have a question over here.
I've heard that in the Medicare for All bill that it still includes copays. And I've heard that the idea for a copay is to discourage people from going to their doctors just for frivolous things. But from that information you've already shown us, most people don't go to their doctors. So just curious as to what your thoughts are on that.
So the bill, as written, HR 676, actually eliminates copays and deductibles. So I don't think that's actually true. No, HR 676, I'm pretty sure has no copays or deductibles. I might be wrong about that, but I'm pretty sure it doesn't have any. Brett, you have something you want?
Yeah, I can touch on that a little bit. I actually was able to sit in on and listen in on a conference call among the Physicians for National Health Program, and they were actually discussing that exactly. And I was very pleasantly, I guess, encouraged by, and impressed that they were actually very critical of that content, that there were copays that were on what was drafted. Yeah, so they were very critical of that. And
so I think we're confusing 2 different bills. The bill that Bernie's thinking of, Bernie Sanders is about to drop a bill in the Senate that would be somewhat related to this. And Bernie Sanders' proposal, as I understand it, although it's not yet public, so I don't know, does have significant copays and deductibles. The bill we're talking about today, without talking about a bill that hasn't been released that I haven't been able to read, the bill that exists today that has the majority of legislators, of Democrats co-sponsoring it, HR 676, I'm not 100% sure, but I'm 99% sure it does not have any. And if it did, they would be small. Let me, if I could, get to the bigger issue, which is, should there be copays or deductibles? That's probably really the issue, I think. So should there be copays and deductibles? The argument for a copay is the skin in the game argument, the idea that if you don't have any cost sharing, that patients will just kind of run to the doctor willy-nilly because, you know, I was gonna go play golf, but it turns out I gotta pay $30 for the tee time. I can get a colonoscopy. You know, people, you know, people don't do that. People don't do that. Instead, what happens is I had a patient that I can remember clear as day who was having what she knew to be her second heart attack, and she was, well, here's a better story. A woman, anyway, we know people all the time who don't get, most patients can't really distinguish between whether it's, how many people go to the ER with chest pain because they think it's a heart attack, but it turns out not to be. To them, it was a heart attack until we can figure out that it's not. Copays are a broad brush that reduce utilization for everybody, and it's not necessary. If somebody, you need to design a system so that if somebody comes in with something minor that you didn't think they could come in, you can teach them about it, give them access to your nurse, give them access to other things. There's no need to do that. However, there's a strong philosophy from folks who aren't as far along on this curve as I might be that really kind of doesn't accept the data around that and says, I think it's a moral wrong to not have people paying part of the visit. So if at the end of the day, the discussion nationally becomes, yes, let's do this, but let's fine tune whether or not there's any copays at all, I'm happy with that discussion. And frankly, you know, that's not to me, that's not the big issue. And if we have to make a compromise on that, I think we can, you know, kind of noodle our way around on that issue. So what else?
Do you have any more questions?
I've got a loud voice. I can just say it's cool. Do you have any concerns about the government regulating the price of pharmaceuticals and medical devices?
So the question is, in case his voice wasn't loud enough, do I have any concerns about the government regulating the prices of medical devices and pharmaceuticals? And before I answer that, let me give you a chance to speak some more, because I suspect with the question that you do have a concern about it.
Yeah, it just seems like they could limit, you know, they have their list of products that they think are valid based on such and such, and then they have these lists that they make way too expensive because of whatever reason they don't think that that's valid. Do you think that it would be up to the doctor case by case, like he says this drug is good, so I'm going to give that to the patient and here's the price that's decent? Or would it be more like the government now regulates what medications patients are able to receive through pricing?
So, important question. Would this create a system whereby another agency outside of the physician is saying these drugs are important and we think these drugs are good for you to have access to, and we think these other drugs are not, and that's a hazard? That why would we want the government to do that? Why would we want to let the government say these drugs are just really not worth it and we're not going to let you have that? What you've just described actually is precisely the way healthcare works today, except that we have private industry making that decision. And I spent years part of that industry making those decisions, and I think I did it in a very ethical way, and I think that the time that I was there, my company was doing it in a very ethical way, and I suspect they still are, but I don't know anymore. But the point is, who do you want to have making that decision? And I think what we want to have making that decision is our elected officials. And every other country in the world, in the modern world, has done precisely that. And it turns out that there's evidence, and you can make these assessments. The biggest problem, and I suspect that the decisions that the government would make about a formulary like that would be very similar to the decisions that all the other insurance companies are making today, mostly because the evidence is the evidence. But the key is we would have one group making that decision. Today, when I'm in practice and I want to give somebody, let's just say Lipitor, I might write Lipitor, and then they go off to their pharmacy and they go pick it up and find out that it's going to be $200 because somebody decided that's not on their formulary. So they call me, I have to get their chart again, or my nurse gets their chart again, and then we change it to Crestor because that's the one that the insurance company has decided. And I can't tell ahead of time whether I should be prescribing Lipitor or Crestor, and I frankly don't care because I'm persuaded that the evidence is that Lipitor and Crestor have very comparable clinical outcomes and do the exact same thing. They're just different flavors, to me, of the same thing. There's the rare patient who needs an exception and needs one and not the other. But for the most part, I don't really care which one of those two, but I want it to be one of those two. I want someone to say, use this one, and not make me have to go back and forth, trying to figure out which one it is. So that's how you would set up a sensible formulary for the country. And that's frankly how insurance companies typically do it today. They go through this process, they see who will give them the best deal on one drug, and so some insurance companies say Lipitor is our H&G agent, and other insurance companies are more effective at negotiating with AstraZeneca, and so they say, no, we're going to have Crestor be our preferred agent. And I'm stuck in the middle as the physician. The patient sees the ads on the TV machine and doesn't know anything about this issue. And no, we want to have one body that's looking at the evidence for the nation, negotiating with the power of the United States government to get the best price on that drug. That negotiation, of course, would have to be at a level where the manufacturer still wants to produce the drug, but not at the egregious, crazy levels that we have tonight. I don't want to go into too much detail about that right now because that's actually the topic of tonight's movie. So come to the movie tonight and we can talk about that a lot more. With the soapbox in my hand.
Questions
In the back?
Okay. Saw this hand first.
Well, thanks. A lot of interesting data. A thought and then a question. The first thought is you implied earlier in one of your slides, and you just said, who would you like making the decisions? And you suggested elected officials. That scares the hell out of me. Because first of all, why would they have to do anything? They've got a sweetheart deal anyway. Their insurance and their coverages are so different than the rest of the country. The best thing I'd like to do is, like you said, put Congress on the same policy that most of the Americans are on. We'll see how much change is there. But my question has to do with scale. We often see these and I don't know the answers, so hopefully you can provide some insight. We compared to Britain and socialized medicine, and even Canada, which has a smaller population and not some of the things we're challenged with. How much of what we have to deal with is because of the scale of our population and the size of our country relative to other countries? I've never been able to reconcile that.
I think that's an important question. You know, we're a diverse nation. You know, we're spread geographically. We're urban and rural. We're all over the place. Probably more so than some countries are, although less difference than you might think. To me, did I say something wrong? I know it's a 10-minute warning. I was told. To me, the most compelling answer to that is the data that I showed you about Canada versus the United States and how we were the same before 1971. We were spending the same, and we were having almost the same health outcomes. And then as of 1971, we chose two different strategies for the country, and one of us continued along the outrageous cost curve, one of us didn't. One of us started having much longer life expectancies than the other. So to me, that's sort of high-level aggregate data, and there's data like that for lots of other countries. I just picked Canada versus the United States. So that to me says that, and number two, I'm sorry, we're the United States, we can figure this out. And the data shows that we did with Medicare. Medicare goes to people in the rural areas and in the big cities and all those places, and the data I showed you about Medicare says it's doing a darn good job, with flaws, with things we need to fix. So I think those are concerns, but I'm confident that we can address that.
My question was related to, with the administrative costs, kind of what are your proposals for, like, what kind of a transition would this look like if you were able to transition over to Medicare for all? Like you said, we just have so many administrative positions. Like, how would you politically approach saying, to hundreds of thousands of people, we're trying to make your job unnecessary, and like, what would be something that would be, like a tenable approach to that?
So there's two different aspects to that. I don't know if you were thinking of both of these. The one is, what do you do with the employment issue? And then the second is, what do you do about the economic impact of making this change? And I think they're both important concerns. So let's do them in order. The employment issue, most of the jobs we're talking about are crummy jobs, and I hate to put it that way. I mean, I know a lot of people in those jobs, and they're great people. They're very smart, very educated, very compassionate. They do hard work really well. They're great people. I'm not criticizing that, but they're crummy jobs, and by definition, I call them crummy because they have 25% annual turnover. So pass this bill today or not, 2 years from now, more than half of them will not be in those jobs anyway. So to me, that's part of the answer. The bill talks about a 2-year income support for the people who would be affected by it. So the day the bill were passed, anybody that's potentially displaced by it would have an income guarantee for the next 2 years, up to $100,000 per year, and be eligible for training and for jobs, and then unemployment if they needed that. So there's that piece of it. Also, in other countries that have done this, other industries begin to prosper because they no longer have to be distracted by, well, Well, you'll see in the movie tonight, that there's this frame manufacturer that's got hundreds of employees that's struggling to keep its doors open in the United States because of the cost of healthcare. There's other companies in Canada that I know of that want to relocate to the United States because this is where their customer base is and they could spend less on shipping. But if they did relocate, they'd spend $1 million more on employee costs, on healthcare benefits. So in general, when countries have made this transition, employment has gone up, and the people who were displaced wound up with a really great place to go. And you can retrain the nurses that are courageously doing their job in utilization management for the insurance industry, retrain them so they can actually be taking care of patients and have a secure, stable, prosperous income. They would be happier. So the employment piece, to me, I think there's strategies to deal with that. The overall economic impact, to me, again, the long-term picture of that is spectacular. Stop diverting so much of our national resource, of our money, to this non-productive use by the insurance industry. Stop diverting that and wasting that. The long-term impact on our economy and making us more productive has got to be favorable. The short-term transition from here to there is frightening. It's 1/6 of our economy, and you're talking about throwing the switch, and if you do the way the bill is written, you throw the switch, and at the implementation date, 1/6 of our economy is structured differently. I don't care how smart you are. I don't care how brilliantly you've set this up. I don't care how much evidence you have. Something's going to go wrong. We've seen that every time. And it's frightening to think about doing that. The problem is we can't keep going the way we're going, right? We're on a truly unsustainable course that's presenting a ball and chain around the ankles of business and making them lose when they try to compete globally, and compete globally is the way you compete these days. So we can't keep going and be the country we want to be. We have to make the change. So we could throw this switch and change the economy with this process, or we could look at transitional strategies. And there are a wealth of transitional strategies. For example, you could do what Johnson said in the beginning, President Johnson, and you could say not 65, now 55. A couple of years later, not 55, now 45. A couple of years later. So you could swing it that way. You could add diseases to Medicare. Today we cover blindness, right? We cover dialysis. You cover Lou Gehrig's disease. You could cover heart disease. You have a heart attack, you're in. Today, it's you have kidney failure, you're in. You could make it, you have a heart attack, you're in. So you could add diseases. You could, there's a whole wealth of incremental transitional. The problem with every one of those, and I wouldn't reject anyone, but the problem with every one of those is that they're more expensive. Because you get all of this side of that chart, and you don't start to get this side of that chart with the savings until you've been able to do the large-scale negotiations, until you've been able to eliminate the redundant bureaucratic administration of the insurance industry. So all of those transitional strategies preserve the insurance industry and undermine all the other benefits until you go the last of those steps. So I don't know the answer, but it's a big important question.
Thank you.
If anyone would like to stay and continue the Q&A, you're welcome to. But to anyone that needs to go, I just want to thank you guys for coming.
My question is does Canada and places like this have a way to offset the extra cost that it does to go into those specialties? So like if you have like radiology, orthopedics, where you have 6+ more years of expenses and what the interest and everything like that, a way to offset that instead of them being like, hey, you're going to go twice as much in debt, but you're not going to make any more than the person that didn't. Is there a way that can be, or is acknowledged or
That's
tackled?
built into the bill, actually. Not in the granularity that I would want, and I hope it's built more granularly, is that a word, into the Sanders bill. But it is actually built into the bill that there's 3 discrete funds for this that are rolled up into the numbers that I showed you. One is for operations, paying for doctors and nurses and stuff. One is for capital, and then one is specifically for education. And they're non-fungible. You can't take one from the other. So, I think the hope and intent of most of the folks I know who are in this position of advocating for it is to make medical school either free or certainly affordable. So, yeah, absolutely, that's a big deal. I see a different pattern here. One, of course, is payment, but these folks don't hear a whole lot of the ongoing stories from patients. These folks hear the stories all the time, right? These folks have the most ongoing relationships. These folks see patients, I'm making this up, but I see it both income related, but perhaps more importantly, I see it as related to how aware you are of what your patients are actually going through. There are certainly exceptions in this group. I mean, this is not zero, this is like 32% or something. And I happen to know a radiologist somewhere near here who's actually really aware of the impact of these stories. Sort of hinting about somebody sitting 30 feet away. So I see it not just as income, I see it as how much you know about what's going on. Yes?
Sort of a devil's advocate question, I guess, quite specific. There were two slides in there noting U.S. life expectancy is lower than.
I think they're recording still, so we might want to use it.
There were two slides in there where you quite convincingly show that U.S. life expectancy is indeed lower than other developed economies. I think the implication made was fixing healthcare would change life expectancy, and I agree maybe a little, but really is that the reason, or do we have other problems compared to that data set like injuries and violence?
So I didn't bring it with me, but there's actually data about that. And injuries and violence, if you look at African American life expectancies versus Caucasian life expectancies in the United States, there's about more or less a 6-year delta between Caucasians and African Americans. And if you look at that, well, what are the causes of it? Roughly 6 months of that 6 years is from drugs, trauma, and crime and homicides and such. 6 months of the 6 years is from that subpopulation having higher of those things you're alluding to. Most of the difference in the most disparate groups is really related to healthcare issues. It's really related to healthcare issues and access to healthcare. Now, is the insurance availability the biggest driver of the outcome difference? And I don't know the answer to that. What I've seen modeling on that when you look around the world is that the variation is roughly 30% explicable by the cost of healthcare, by the way healthcare is financed. So no, it's not the biggest piece. But I think there's other implications of it as well. For example, there's whole regions of our country where there are almost no doctors, right? And there's almost no doctors because, well, some of us just really like practicing in cities, I guess. But there's also almost no doctors in some of these areas because you can't make a living. That's where look at the boot heel. You know, that's where uninsurance is the highest, and that's where the death rate is the highest in Missouri. So if I wanted to go and set up a clinic in the boot heel, I'd have to be prepared for having a huge number of my patients not having insurance. So if instead you provided blanket insurance for everyone in the country, that you knew was going to be there, I would have a business case for going to the boot heel, and I don't today. The ACA tried to do that a little bit. They set up a thing where for 2 years they were guaranteeing that Medicaid would be reimbursed at the same level as commercial insurance. They've set up a 2-year window, and it didn't make any difference. It didn't actually set up these practices because it was a 2-year window. It took them months to get it started. And who's going to set up a practice in the community based on a 18-month payment opportunity, And it did expire, and they didn't bring it back. So we haven't really tested that. But my thinking is that although healthcare is only maybe a third of the difference in life expectancies that you're talking about, it would have repercussions elsewhere. For example, too, you open up a clinic, you open up a hospital, you bring in jobs, those people then start shopping at the cleaners and start shopping at the hardware store and start doing other things. And you close a hospital or a clinic in a community, and those people lose their jobs, and all those other secondary benefits of having employed opportunities in it start to disappear. And we're seeing that around Missouri today. So, yeah, it's not. I may overly strongly state that this would solve the world's problems, but no. The point is what I just said. And the number two, this is the only way to establish a long-term business case for the other improvements.
There's an excellent answer. And then a perfect segue into my next question. The only way you present the argument for single-payer Medicare type plan well. Are there groups out there with something that, on the other side of the spectrum, that keeps a capitalistic approach, a competitive approach? No doubt, the system before the, what's the correct name? The Affordable Care Act and the Affordable Care Act are economic disasters. Is anybody out there advocating a way to fix it with a system that retains competition?
I'm not sure I totally understand. You're asking what are the
Well,
barriers to making this go forward?
You
or-
present a single payer system and, you know, many of the attributes and how it would fix things. Is there any other group out there advocating keeping a, you know, multiple payer system in there where the driver of bringing down cost is a system of competition that would actually function correctly or function efficiently?
Well, actually, I think what you just described is the majority opinion of the Democratic Party. I think what you've just described, right, is keep the, you know, the ACA, which is modeled on a private competition of insurance companies. I think that's the model that they're the most advocating for. You know, and then there's sort of the other extreme, which is advocating for what you could almost call Cambodian-style healthcare. I love Cambodia, but their healthcare system doesn't exist. You could argue for a healthcare system that's just completely free trade. You know, you get sick, you go to the doctor, you bring your cow, you give it to the doctor. You know, you ran out of cows. I guess you're really not socially worthy of keeping alive. You know, there are people who think that. That's a minority of Americans. I mean, that's like in the single digits of Americans that really think that extreme about competition. So this middle position of let's make the insurance companies more able to compete in a free market, that is the direction of the Affordable Care Act, and there are things you can do in the Affordable Care Act that will make that more effective. And indeed, the Affordable Care Act as originally written includes some of those that have been impeded from being implemented. So you could do that, you could do more to that, you know, and there's, you know, we could talk about lots of other strategies that could be done to make the ACA more successful. There is that. But I would say that that's all, and I would support that. You know, if we don't get this, I would support this. You know, so I would, you know, but it's a fallacy to think that we're ever going to achieve the goals we want by having a free market of insurance companies. That's not what they want to do. Insurance companies want to find the healthy, shun the sick. You know, that's not what their business model is, to game it and make the most money they can off of it. It's not to deliver the, you know, they sound like they want to do best healthcare, but that's not. We're never going to get to where we need as long as we keep propping up the insurance industry.
Any more questions? Sure, Thomas.
Hey, so not a question so much as a comment, but someone asked a question earlier about employment after the ACA or after Medicare for All was passed. I don't know where this is worked into the literature of HR 676, but I do know in the bill that Bernie Sanders is planning to release, he has worked in a provision of some sort so that there is an employment transition. And it, like you were saying earlier, does work to train people, but not necessarily for healthcare provision, but as managers of the Medicare for All type system, because there will still need to be a great deal of management. It's just one single place. So it's everyone doing the same type of management versus 1,000 different insurance companies and different policy things. It's everyone in that one single payer system, but there still needs to be that number of administrators to keep everything on track.
Yeah, no, that's true. Their work doesn't go away. It just becomes a fraction of what it is today. And yeah, they'll be, I'm sure that's what the resource will be tapped by. Yeah. He hasn't released the bill yet. There's a policy statement on his blog that, you know, goes through what you would think would be all the elements of what the bill's going to have. And that does talk about what you just said, but the bill hasn't dropped yet. And so we don't really know that. And there's a lot of things in the blog that he said that a lot of folks on both sides of the argument have been critical of in sending him their discussions about it. So I don't know that the bill is going to precisely one-to-one match of what's in that blog. So we don't know what he's going to submit. But I'm sure it'll have something about this, because how can you not?
I was wondering if you could just help to elucidate a little bit about for under a single payer system, how would the accessibility of treatments and procedures compare to kind of what's...
Of what?
The accessibility of treatments and procedures compared to what we're looking at now in terms of our current system. And I mean, obviously compared to the Canada system, the wait times is the biggest kind of inhibitor of treatment. as opposed to cost in this country, but would there be a lag in being able to access certain care here under a single-payer system?
So that would be up to us, right? We would get to decide, through our democratic process, we get to decide where the resources get allocated, and we would be able to align that with public health requirements. So that would be a national prioritization decision. In general, since the end result is that if the system were to not provide a form of care that actually was important at mitigating morbidity and mortality, then the same system would be the one that would reap the consequences of the higher cost of failing to provide that care. My wife accuses me of using unnecessarily complex sentences, and I think I just did that.
Invisible hand principle, I see.
But I think you understand my point. My point is that when you have complete capture of the system, when the Medicare for All program is the same group, the VA did this, right? The VA figured out that if you're a veteran in 2017, if you're not dead, you're still going to be a veteran in 2030. They figured this out in the mid 80s. They figured this out, and so they have been dinged pretty severely about some service issues. But they actually have many programs that improve the health of veterans as a consequence of realizing that if they don't do that, when they do that, healthcare is better and healthcare expenses are better. So that's the same thing that would happen under this. So when I spent time as a medical director of insurance companies, and I tried to put in programs that would, I thought, have health benefit to the membership, and that would, because it would make people healthier, it would reduce costs on the back end, and I thought that was a great win-win. Well, it turns out that, much like the employee number that I quoted, insurance companies know that 20% of their membership turns over every year. Change jobs, your job changes what they offer, you lose your job, you pick a different one of the options. 20% of Blue Cross's membership, in every insurance company generally, changes every year, which means that when Dr. Nice is out here trying to put in a program that's going to do a campaign to improve whatever, the insurance company is looking at that and says it's got to have an ROI within 2 years, because if you're going to do something today that makes people healthier 5 or 10 years from now, the chances are you're improving the health of my competition. So there's a perverse incentive under today's program to create the problems you're talking about. If they're valuable programs, if they're actually things that do improve health, there's a perverse incentive today to not reward those things. And this strategy would actually align those interests and make a business case for improving public health.
Thank you.
That's probably enough.
All right. Yeah.
All right.
Thanks for coming, guys. Appreciate it.